schools. That's the biggest university in Iran. So we can start the program. Hello everyone, it's 7:30 p.m. in Iran and it's time to start the program. First, I will briefly introduce myself. I'm Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Oncology, Hematology and Cell Therapy Research Institute and head of the leading house for Iran North America Academic Partnership. We are pleased to present the first part of the Tehran University of Medical Sciences Board Review Series entitled Hematopoietic Stem Cell Transplantation. The TUMS Board Review Series is an educational program planned by the leading house for Iran North America Academic Partnership, and the program provides a unique opportunity for fellows in training, physicians planning to take the hematology or medical oncology certifying exams, or physicians wishing to review the established standards of care in hematology, medical oncology, and stem cell transplantation, and to learn from well-known expert hematologists and medical oncologists from the US. Case presentation will be accompanied with polling from the audience to get feedback about how they learn from the speakers. At the end, we hope the audience has gained knowledge helping to prepare for the hematology, subspecialty, and certification examinations. Utilize current standards of care for patients with cancer, blood disorders, and malignancies, and incorporate recent advances into management of hematologic patients. The review series was realized with help from the Oncology, Hematology, and Cell Therapy Research Institute, the Appraise to Raise team, and the support of the Vice Dean for Educational Affairs of International Campus. I would like to express my most sincere gratitude for the support and welcome to this educational program. It's a great honor for us to have you all here, at least virtually. Before we start, I would also like to thank our invited speaker, Professor Dr. Mark Stewart. And Dr. Mark Stewart is the Vice Chair and the Clinical Professor at the Department of Hematology and Hematopoietic Stem Cell Transplantation at City of Hope. He kindly accepted our invitation and would like help us to foster the scientific collaboration and connection between hematologists in Iran and the US. I'm now asking Dr. Rostami and Dr. Rod, our moderator, to introduce our valued guest speaker. And following that introduction, we will start the program. I hope you will find this webinar informative and helpful. Dr. Rostami, please introduce our speaker.
Thank you, Dr. Yaghmai. Thanks to the organizers of this virtual meeting. Good morning, good afternoon, and good evening. Welcome everyone to our today webinar entitled Hematopoietic Stem Cell Transplantation Board Review. I am Tahera Rostami, Assistant Professor of Pediatric Hematology, Oncology, and Stem Cell Transplantation at Research Institute for Oncology, Hematology, and Cell Therapy affiliated by Tehran University of Medical Sciences. Jointly with my colleague, Dr. Surush Rad, I will moderate this virtual session. So thank you for joining us. Actually, it's my great pleasure today to introduce the speaker, Dr. Mark Stewart. Dr. Stewart is Clinical Professor of Hematology and Oncology. He's Vice Chair of Hematology and Hematopoietic Cell Transplantation, Department of the City of Hope. And he served for 2 decades as Medical Director of Seattle Cancer Care Alliance at the Fred Hutch Cancer Research Center, and also similar leadership roles at the University of Massachusetts and the University of Virginia. Dr. Stewart's research interests include the biology of engraftment, cellular immunotherapy, and drug safety, and also healthcare delivery. Please join Dr. Stuart and welcome him. Just before that, let's listen to Dr. Rod. Dr. Rod, please.
Hello, good evening, ladies and gentlemen, dear colleagues. My name is Surush Rod. I am the Assistant Professor of Hematology and Medical Oncology at Tehran University of Medical Sciences. I'm so honored to introduce this webinar entitled Blood Board Review of Hematopoietic Stem Cell Transplantation. It is a great opportunity that we have Professor Stuart here. This program will run by case presentation, and we plan to have interactive polling system. You have 30 seconds for selecting your choice, and then Professor Stuart will discuss the cases. Asking audience participate actively in polling. This is important to submit your answers, and we strongly encourage you to participate by writing questions and comments in chat box during this session. Professor Stuart, the microphone is yours.
Good morning. Can you all hear me?
Yes.
Great. Well, thank you for the invitation. You know, I understand that I have had some great colleagues visit Tehran. I see Dr. Shadman online here, so hello to him. He's one of my colleagues, former colleagues at the Fred Hutch and University of Washington, so it's great to see him online. And hopefully he can add a few points as we go through the presentation. So I'm going to start out with a kind of a very, very brief overview of some of the trends in transplant and some of the niche diseases where transplant has been used more recently, and then we'll launch into the cases. So to begin with, you can see here, this is the CIBMTR database. It is an international database, so not just the US, although this is US data here. But basically what it shows is the number of transplants that have been performed over decades since 1980. And you can see that...
Excuse me, please share your slides. We cannot see your slides.
Oh, you can't see the slides?
No.
Okay, how do I have to share the slides?
Yeah, share a screen. Just
okay.
click on share screen.
Yeah, the share function's not working.
Dr. Rod, you have the slides of Mark, and you can share your screen if Mark cannot share it.
Yes,
yeah, don't worry, Mark. Dr. Rod can share your slides.
Yeah, it's kind of interesting. We just did it, didn't we? Yeah, I guess I still don't have a share function.
sorry to interrupt. Dr. Rod, can you remove the optimize teach whenever you share your slide?
Did you share it?
Yeah, wait a moment. Dr. Rod, please share your screen. Okay. Okay.
Okay.
And go to the full screen mode.
Play.
Okay.
Great. Thank you. All right. Well, so as I mentioned, this shows trends of numbers of transplants, and you can see here in the blue line that back in 1980, allogeneic transplants were performed really even before many autologous transplants for over almost a decade. And the number of allogeneic transplants gradually increased and continues to increase over the years. But in 1989, Dr. Fred Applebaum from the Fred Hutch published a paper from the NCI that showed that autologous transplantation in lymphoma was potentially a curative treatment. And so he accomplished that. And since that time, autologous transplantation has taken off in a variety of diseases. Now, what you can see here is the number of allogeneic transplants by category. So here, you can see the number of matched related donors, and those were the ones that were initially performed in the early years. But, you know, after a while, there was a plateau in the number of matched related brother-sister kinds of transplants because of family size limitations. And so even before that, there were registries that were developed that could allow us to use unrelated donors. And you can see that eventually the unrelated donors in 2007 exceeded the number of matched related donors, and those continue to increase. In fact, the matched related donors seem to be plateauing off here a bit. The other source of stem cells was cord blood stem cells, and there was a lot of enthusiasm in the early part of 2000 for about a decade for using cord blood cells. Cord blood cells are an interesting stem cell product. There's a concentrated amount of stem cells there, which allows engraftment. And so it seemed like a perfectly reasonable source of stem cells. However, it is associated with a fair number of complications, largely infectious complications and some graft-related complications. And what's come into effect here now is really more of the haploidentical transplants that have gained increasing frequency here as a source of stem cells. Next slide, please. Now, the other thing that's important, I think, is the age effect over time. And as you can see here, most transplants are done in patients who are under the age of 60. But increasingly, over the last decade or so, the number of patients transplanted between the ages of 60 and 69, and even over 70, has increased fairly substantially. And you can debate about whether or not this is a good use of healthcare resources. Some of the data suggests that you can get relatively good outcomes in older age patients like this. However, the cost of transplants, at least in the United States, is quite high. Next slide. So one of the questions is, how do you use autologous transplant? Increasingly, autologous transplant has been used, of course, in multiple myeloma. And this is a study that looked at double transplants versus double transplants plus Revlimid, Velcade, and dexamethasone, and then a transplant with other maintenance type of therapy. And you can see that there's really not a lot of difference in the overall survival rates. And this was published back in 2019. A fairly large number of patients in this comparison. And so in previous years, we've relied maybe on two autologous transplants for myeloma. This paper might suggest that it doesn't make too much difference, although there may be select cases where a second autologous transplant might be useful. Next slide, please. So now the other interesting thing, and I'm not going to talk much about this, but it's changing the field of transplant in a way, and that there are trials now that are evaluating CAR T-cell products compared to chemotherapy followed by stem cell transplant, in this case in second-line relapsed or refractory large B-cell lymphoma. And this is a report, a preliminary report as of June of 2021, and it demonstrated a highly statistically significant improvement in event-free survival, response rate, and progression-free survival for the CAR T cells compared to auto BMT and chemotherapy. So we're probably going to see more studies like this, and it'll be very interesting to see what the role of CAR T cells will be compared to some of these more traditional treatments. Next slide, please. Now, I mentioned some niche diseases. So this is a paper that was published back in 2019 by Richard Burt. I met Richard Burt when I first was introduced to Seattle. He was doing a rotation there, quite an interesting fellow. And what he did was he did a randomized study of looking at autologous hematopoietic stem cell transplants versus other disease-modifying therapy for multiple sclerosis. And what he was able to show was that the time to progression and the time to first relapse was significantly reduced in the auto transplant group, and that these results seem to be sustained out for as long as a median of 6 years, which I think is pretty impressive. Now, neurologists have always been a little reluctant to jump on the bandwagon to give autologous transplant for multiple sclerosis, but the National Medical Advisory Committee of the National MS Society here in the United States has developed some criteria where they think you can use this modality. In younger people, they recommend in people who have had multiple sclerosis for 10 years or less, and that have this breakthrough disease activity despite treatment with otherwise what would be considered highly effective therapy. Next slide. So the other niche disease was severe scleroderma, and here we have Dr. Keith Sullivan, a former Hutch professor who did a randomized study of auto stem cell transplants versus cyclophosphamide in patients with severe scleroderma. And you can see here, again, transplant seems to prolong overall survival and event-free survival in this otherwise fatal disease. Next slide, please. I just want to call to your attention a couple of review articles that are very, very good if you're trying to do stem cell transplants and have the challenge of COVID in your community or in your country. And of course, all of us have had that challenge to varying degrees. But these articles, I think, are really good. I'm not going to go into them, but they outline an excellent approach for how to manage transplant patients during the time of COVID. Next slide, please. And then finally, the other niche disease I was going to touch on, this was published in 2021 in the European Journal of Hematology. This is a group of sickle cell anemia patients who had vaso-occlusive crises. And so they were homozygous sickle cell patients. There were 204 of them. This was taken from the United States Medicaid registry. So all over the country here, and those that were transplanted. And you can see that 2/3 of the BMT recipients were free of their crises for over 2 years of follow-up. But there were, of course, as you might expect with an allogeneic transplant, transplant-related complications, including graft versus host disease, which occurred with a higher than what we would like frequency. So the controversy, of course, is do you trade one disease for another in patients with sickle cell anemia? And I think that's one of the things that has slowed the adoption of allogeneic transplantation in our patients with sickle cell anemia. Next slide, please. Now, as you think about how to select an allogeneic donor, and there are a number of choices here, the conventional practice in order of preference is first to select an HLA-matched family member as the best match. And then if that member, if a family member is not available, then to go with an unrelated donor, if at all possible, and to get an 8 out of 8 match. In most cases, you'll be able to find an unrelated donor, but in some ethnic minorities in the United States, that is still a problem. And so over the last couple of decades, people, as I mentioned, have looked at alternative donor sources, the haploidentical, the cord blood, and the mismatched unrelateds that are mismatched at one of the major loci. These obviously carry some risk, as we'll talk about later, and but the good news is that we are likely to be able to match for almost every patient that we see now. Next slide, please. Now, there are a number of secondary factors that are important for selection. One, which has actually turned out to be pretty significant, is age of the donor. So it's relevant if you have multiple donors that are available. So the older you have the donor, the higher the mortality rate. And so it's about a 3% for each decade increase in age of the donor. And then the other part is the CMV status, and the current recommendation is CMV donor positive to CMV positive recipient. And if you happen to have a CMV negative recipient and a CMV negative donor, that is the best combination, because those patients, if managed properly, rarely get cytomegaloviral infections. ABO red cell mismatch usually has little effect, other than occasionally to cause a delayed hemolytic anemia. Next slide, please. Now, the other important point as you begin to look at HLA typing is to begin to look qualitatively at some of the antigens here. And these are genotypic antigens, and they have been categorized now based on their immunogenicity, that is their T cell epitope group. And so you have greater immunogenicity in a T cell epitope group of 1 versus 3. And this is just based on outcomes such as graft versus host disease, and perhaps some in vitro studies. Next slide, please. Well, this is a study that was published by Effie Petersdorf in Seattle. And again, it's looking at the HLA DPB1 loci here that you see. And basically, if you are a high expressor of these antigens, you will have a higher graft versus host response. If you are a lower expressor, and this is genetically determined, you see here by the number A, or the letter A in this sequence, versus the letter G. So if you have the genetic type of A in this sequence, you're a low expressor, and the graft versus host disease response is lower. So this is really important, because not only do you match for the antigen here, the DP, but you also match for how well it's expressed as determining whether or not you're going to develop severe or mild graft versus host disease, for example. Next slide, please. So as I mentioned, the alternative donors are cord blood, haploidentical, and mismatched unrelated, particularly those that are higher risk for the mismatch at A, B, C, and DR. And this is a much higher risk, perhaps, than some of these others, of course, depending upon how well matched a cord blood unit or two is. Next slide, please. So one of the studies that came out recently, and we had Dr. Paul O'Donnell, who was at our institution in Seattle, participate in this BMT CTN trial, which was double unrelated cord blood versus haploidentical transplant. And the bottom line here is that the haploidentical transplant seems to produce a better overall disease-free survival. The non-relapse mortality was 18% in the umbilical cord blood versus the haplo, and the graft versus host disease was about the same as was time to platelet recovery and incidence of relapse and progression. Next slide. So let's start our cases. And the first case is a 25-year-old otherwise healthy woman who was diagnosed with severe aplastic anemia and is being evaluated for a potential allogeneic stem cell transplant. So which of the following donors would be best for her? A, an HLA matched 10 out of 10 sibling peripheral blood stem cell transplant. The same with a sibling bone marrow transplant. And the same with an unrelated donor peripheral blood stem cell transplant, a haploidentical sibling transplant, or an HLA matched 4 out of 6 cord blood donor. So take a moment and think about this, and I guess we'll start the poll.
I'm asking the audience, please select your choices.
All right, are we almost done? Great, well, looks like most of you got the right answer. The right answer is an HLA matched sibling bone marrow stem cell donor. So let's go on to the next slide. So we can stop the poll.
Dr. Rod, you should share your screen and show the slides.
Okay, can I? Are you doing that or am I doing that?
Dr. Rod, you should launch next slide.
We're having trouble closing the screen.
Dr. Rod, can you hear me?
Yes, I have a problem with the sharing this.
Dr. Rustam, can you share the slides? Oh, okay, it works.
it works?
Yes, it works.
Okay, so I mentioned that the answer was B, that is bone marrow. And bone marrow has largely been, though not exclusively, preferred as a source of stem cells for patients with aplastic anemia. And one of the reasons is aplastic anemia is not a malignant diagnosis. It is it's a disease where maybe a graft versus tumor effect is really not required with the development of graft versus host disease. And there have been studies that have shown that bone marrow is associated with a lower incidence of, in particular, chronic graft versus host disease. So that's the other important point is patients with aplastic anemia, if they get bone marrow, they're less likely to have a chronic graft versus host disease, which significantly impacts their lives. Next slide. Here you can see the CIBMTR data for the results in adults of transplant for aplastic anemia, matched related donor versus unrelated donor. And next slide. And then, as I mentioned, bone marrow is associated with better patient-reported outcomes than peripheral blood transplants in survivors that are out 5 years after an unrelated donor transplant. There seems to be better psychological well-being, fewer chronic graft versus host symptoms, and more likely to return to work. And this was a study that was done by Stephanie Lee at the Fred Hutch. And the survival, relapse, and treatment-related mortality, however, were similar, whether you use peripheral blood or bone marrow. Now, the interesting thing is that despite this information, we really didn't see an increase in the proportion of stem cell transplants using bone marrow. And I suspect that has a lot to do with the convenience of being able to obtain peripheral blood. However, I think in diseases like perhaps sickle cell anemia, aplastic anemia, where you don't really have a malignant disease, bone marrow would be the treatment of choice, if at all possible. And I should say that bone marrow, in some cases, not all, it's being increasingly used in peripheral blood for haploidentical transplants. But at least initially, people started out using bone marrow. More frequently now are using peripheral blood. Next slide. Okay, second case, 40-year-old woman has undergone a haploidentical donor's transplant for AML. On day 25, a routine piece, oops. Can we go back? Well, you guys are way ahead of me.
Please close the poll. Close the poll, please.
Okay, so I think you've already answered the question, which is the correct answer. The correct answer here is, and I didn't finish reading it, but it sounds like you all read it quickly. This patient was on acyclovir, didn't have any symptoms of pneumonia, had a normal creatinine, and the answer here was switching from acyclovir to valganciclovir. And then other choices here were to use letimavir, increase the acyclovir dose, switch acyclovir to valacyclovir. All of those are the wrong answers. Okay, can we go to the next slide? So I think the point here is can we go back? Okay, the point here is valganciclovir can be given if oral intake is good, there's no diarrhea, or graft versus host disease, and good renal function. Otherwise, one would use intravenous ganciclovir. The dose is correct. And letimavir and acyclovir are really not indicated for active preemptive therapy, that is, with a rising CMV PCR. There's a higher incidence of CMV viremia in haploidentical transplants. And the real catch here is, at a minimum, letermovir should have been started in this patient for prophylaxis. So I didn't mention that in the story, but one criticism would be that this should have already been in place as prophylaxis for this patient. Next slide, please. And this is just a slide that summarizes a study with comparing letermovir versus placebo, showing that the cumulative rate of infection with CMV for clinically significant CMV infection was significantly reduced in the patient group that received letermovir. So again, using this in our study problem up front would have been appropriate. Next slide. Okay, a 55-year-old man is day 35 after a matched unrelated donor transplant for MDS. He received tacrolimus and methotrexate as prophylaxis for graft versus host disease. His most recent TAC level was within normal limits. And in the last few days, he developed diarrhea that was significant. Flexible sigmoid studies were negative for infection, but he was diagnosed with acute gastrointestinal graft versus host disease and placed on methylprednisolone 2 milligrams per kilogram, but experienced very little improvement in his symptoms after 1 week at that dose level. So the question is, which of the following options would be appropriate? And I guess you've already seen those, so. Yeah, you guys don't need a board review course. Okay. Great. Shall I end? Okay. Are we finished? Okay, so the answer, the correct answer, next slide, is A, adding ruxolitinib. Ruxolitinib or Jakafi is second-line therapy for steroid refractory graft versus host disease and is FDA approved for both acute and chronic GVH. Some people selected MMF, but mycophenolate mofetil is really not likely to be effective for the treatment of established GVH. Sometimes we throw it in, but it's usually used more for prophylaxis. It may have some GI toxicity as well, and there are other compounds of MMF that may lessen the GI toxicity. The other option is to increase the dose of methylprednisolone exceeding 2 milligrams per kilogram, but that's unlikely to improve graft versus host disease and would probably lead to higher rates of virus and fungal infections. Ibrutinib has been FDA approved for chronic GVH, not acute GVH, and extracorporeal photopheresis is clearly an option for patients with graft versus host disease. But usually those with skin and liver disease, it seems to be a little less effective in gut acute graft versus host disease. Next slide.
Okay. Sorry, Mark. I have a question. But,
sure.
Actually, ruxolitinib is not covered by insurance service in Iran. On the other hand, it may not be affordable by most patients. So what's your alternative choice?
Well, that's a great question. You know, some people might go back to ATG as an example for refractory disease. You know, using, you know, the prognosis if you are steroid refractory at 2 milligrams per kilogram is pretty dismal. But I think some people, I don't know, do you have ATG as an option?
Yes, we have ATG.
So ATG would be one option. You know, there are other compounds you can try, I suppose, like sirolimus. But I think the patient's in trouble if they are refractory to a 2 milligram per kilogram dose. But those would be examples. There are lots of things that we try in steroid refractory GVH before Jakafi. And I don't know if Dr. Shadman wants to comment, but you know, it seemed to be dealer's choice for different things to try with no clear winner until this drug came along. So,
Mrs. Sadegh, please give the microphone to Dr. Shadman.
Dr. Stewart, before Dr. Shadman, I will ask you about your definition of response or resistant to Jakafi. I mean, your endpoint is day 28 after starting Jakafi?
no, I think it all depends on when you develop the graft versus host disease, right? So in this patient, we treated the patient for a week and didn't see any signs of improvement. And so I think it depends on when it starts, not necessarily what day it occurs post-transplant. I think you give it time, give the steroids time to work, and then you try Jakafi. I should say that, you know, GI graft versus host disease, and Dr. Shadman might comment on that, is when it's chronically at a level of 2 or 3 liters a day is a very difficult disease to treat if it's been refractory to steroids and other immunosuppressives. We can have patients in the hospital for months sometimes, just giving them hydration, replacing their fluids, treating them with pain medicine for the GI pain that they sustain. It's a very difficult disease to treat. Happily, Jakafi has come along and I think produced some better results and better responses. Dr. Shadman.
Hi, I just wanted to say hi to Dr. Stewart. I totally agree. Outside of Jakafi, really, there's no standard of care. And if ATG is available, that would be probably the preferred choice. But really, one of the key factors is to start having a discussion with the family and family members and make sure that their expectations are realistic when we get to steroid refractory GVHD. Unfortunately, really nothing. The chance of success is extremely low regardless of what you use.
Thank you, Mazar, and welcome. It's nice to hear your voice and to see your photo.
Thank you.
Okay, so next slide. Oh, okay, here we are. So 62-year-old patient diagnosed several years ago with AML and has the mutation profile you see there, 65 days post-transplant, no evidence of graft versus host disease, somewhat refractory to initial treatment, received a haploidentical transplant with the conditioning that you see there. His donor was a 39-year-old son. You can see that he received post-transplant cyclophosphamide, tacrolimus, and MMF. He achieved a complete remission with minimal residual disease negativity at day 30 post-transplant. And he was 99.9% donor on chimerism studies. So, of course, you were concerned because of his highly refractory disease initially, and so you repeat blood chimerism studies. And again, the flow cytometry shows no evidence of disease. MRD results are pending at 60 days. The peripheral blood chimerism, however, shows a decrease in CD30 levels to 80%, with a tacrolimus level relatively normal, a little on the low side. And so the questions are, next slide. Oops. Are we doing the poll? Can you all see the questions? Okay, looks like you guys got the right answer. That's excellent. So the next best step in management would be to begin to taper immune suppression in order to get a better graft while you're waiting for the minimal residual disease studies. And I think the point here is that the reappearance of host chimerism has been strongly associated with relapse. Wasn't terribly unexpected in this patient, but it's kind of a surrogate for a marker of minimal residual disease. So although we don't have the MRD results available, probably likely that those will become positive shortly. So early withdrawal of immunosuppression, sometimes followed by maybe chemo and DLI, might be helpful to reinduce a remission, but one's dealing with pretty resistant disease here, and so the question would be how effective that would be. Certainly it is something that we try at some centers. I think it would be important to know whether there was in fact MRD before one would launch DLI and so forth. One of the choices was to do a T-cell depleted stem cell boost, but that would be considered experimental and would not likely, of course, affect leukemic relapse without T-cells. And since he relapsed, or since he is having issues early in his transplant course, if in fact he relapsed, it would really be too early to consider a second, even minimally ablative transplant, at least as we would view it. Next slide.
I have a question.
Sure.
What's your opinion about maintenance therapy after transplantation in this patient? Something like
it's a good question. I think it is still considered experimental to do maintenance therapy. I think there are a number of studies ongoing that are looking at that question, but I believe we would probably consider this not necessarily standard of care, but if the patient's eligible for a clinical trial that's looking at that, totally reasonable thing to do. Mazar, do you have any comments about that?
Dr. Stewart, I have a question. Dr. Shadman, please.
No, I just wanted to say I agree. I don't think this setting there's a randomized trial, but I was trying to unmute myself.
Yeah. Dr. Stewart, I have a question. If a positive MRD is reported in your patient, what's your next step? Given that the patient is resistant to azacitidine, do you recommend, for example, venetoclax for MRD positive in this patient?
Well, you know, it's hard to know. I think one of the things that what we would probably do in the absence of graft versus host disease is we could try donor lymphocyte infusions after some chemotherapy. That is probably what we would do here at City of Hope. Maybe what we would do at the Hutch, although I think the Hutch has some research studies that might be applicable, but probably wouldn't necessarily I mean, treating with chemotherapy is okay, but he had chemotherapy before, right? So I think chemotherapy would probably only maybe prolong a partial remission or maybe put him into a temporary complete remission. I think what we would like is something that would be more sustained, that you might get with a DLI effect and a graft versus leukemia effect. But the guy has pretty resistant disease, so I can't say that that would be a magic bullet, but that's probably what we would do. Okay, a 46-year-old male who is 190 days post peripheral blood stem cell allogeneic transplant develops dry mouth, dry eyes, and a skin rash. This is manifest as tightness and thickening over the forearms and thighs. There are no contractures noted. He has some shortness of breath. Pulmonary studies suggest obstructive airways disease. There's no evidence of infection by bronchoalveolar lavage, and a diagnosis of chronic graft versus host disease is made. Next slide, please. That's an example of his skin rash. And then the question is, which of the following is untrue about chronic graft versus host disease? Okay, and so the answer is, let's go to the answers. The answers are all except D, so I think some of you got that right. The patient's symptoms are characteristic of graft versus host disease, and the longest duration of steroid therapy is associated with peripheral blood, not bone marrow. Peripheral blood having 3.3 years median of symptoms with chronic graft versus host disease, followed by bone marrow, followed by cord blood. Next slide. So this is a good slide because it, and it's again a slide we borrowed from Dr. Carpenter at Fred Hutch, showing some of the symptoms of acute graft versus host disease. The classic interval of time when classic acute graft versus host disease is occurs, that is between day 0 and day 100. And then the classic chronic graft versus host disease, which usually occurs somewhere between day 90 and on, and has these features that we described in this patient. Now you can see that there's an entity called late acute graft versus host disease, which you'll see in a second is associated with a higher frequency in cord blood transplants. And then there's this overlap syndrome that has features of both classic chronic graft versus host disease and classic acute graft versus host disease. Again, it tends to occur later after day 90 or 100. Next slide. So with that in mind, and this reiterates what we mentioned in the case, the median onset of chronic GVH is about 6 months. 10% happens occurs greater than a year after transplant. And the diagnosis usually requires a diagnostic sign or a distinctive feature. The distinctive feature would be the Sika syndrome. A diagnostic sign might be scleroderma or sclerodermatous esophagitis. And so there is a whole set of signs and features that one can look at to make a diagnosis of chronic GVH. So again, back to our question, if you look at the source of stem cells for cord blood, The incidence of chronic graft versus host disease is about 32%. However, about 64% for what we looked at previously called late acute graft versus host disease. And the median onset or the median years on systemic therapy was about a year. For marrow, the incidence of chronic is about 48%, and for peripheral blood, as we've mentioned before, is about 60% with a more prolonged duration of therapy. Next slide, please. So case number 6, a 58-year-old male, 79 days from an HLA-matched unrelated donor transplant, continues on tacrolimus and lorazepam or Ativan for anxiety and low-dose steroids for acute graft versus host disease. He developed some sustained symptoms of confusion. An HHV6 PCR study is performed, and I think it's on plasma actually, and the CSF is positive. Both serum and CFS are positive. Further analysis shows the HHV6 to be chromosomally integrated. So he's on a cyclovir and letermovir. CMV studies are negative. His CSF studies are otherwise normal. So at this time, you would recommend treatment with ganciclovir plus an attempt to reduce or discontinue the sedative that he was on. Treat as okay. Okay, great set of answers. Excellent set of answers. We'll give everybody time. Okay, so this is a little controversial, and we'll explain what we mean by chromosomally integrated HHV6. So the preferred answer, at least according to Dr. Hill from the Hutch, who I asked him to review this question, is answer E, which takes a minimal approach. That is, let's find out why the patient is confused and not necessarily attribute it to HHV6. So the reasons are chromosomally integrated HHV6, which is different from free plasma HHV6, is usually not clinically significant. This is an inherited abnormality, interestingly, and so you would find this in all of the cells of the patient. Hence, initiating ganciclovir might be considered over-treatment. Now, the dilemma, of course, is how can you measure chromosomally integrated HHV6? And there are only a few labs in the country, I think, probably an increasing number of labs in our country, that are being able to measure this entity. But it can be confusing because you can have a positive HHV6 where you're measuring this, the chromosomally integrated HHV6, which is probably not clinically significant. So in that case, addressing the mental status changes by reducing or discontinuing the sedative, obtaining an MRI to rule out posterior reversible encephalopathy syndrome or PRES might be the answer. Now, if you don't have that assay, it's likely that you might have to treat patients, and it's a difficult dilemma. Next slide. So this was a study, and it's worth going back. It was just published in June 2021. It is from the Hutch, and Dr. Hill and Dr. Heldman and coworkers looked at this, and they looked at 87 patients who had chromosomally integrated HHV6, and they compared that to 174 matched controls without donor or recipient integrated HHV6. The clinicians were unaware at the time of that chromosomally integrated HHV6, And they found that the central nervous system symptoms were about the same in each group, so that the cumulative incidence of CNS symptoms was similar, and that a plasma HHV6 as an indicator of infection in someone who is chromosomally HHV6 integrated could lead to unnecessary overtreatment. In some cases, patients got ganciclovir. In other cases, 2 patients here who had chromosomally integrated HHV6 underwent a lumbar puncture, even though they had no CNS symptoms. So it's an interesting paper, and it's a challenge for how to manage HHV6 without this particular test. So again, I might ask Dr. Shadman to comment on this and get some of his advice about how he might manage this. I think in Seattle in years previously, we would just treat a positive HHV6 given some of the devastating consequences to the brain that can occur. But Mazar, what are your thoughts?
Yeah, so I don't think I have actually experienced, I don't think I've attended after this paper. I have to be honest, yeah, as you mentioned, we used to treat, but I have not encountered a case with this new data. So I don't know. I see Dr. Hill in an hour. I can ask him how we do it these days, but I don't know the answer.
Well, it's interesting that this is probably pretty infrequent. The hereditary presence of HHV6 is about 1% to 2% of the population, so it's a low rate. The test that's done at the University of Washington is a test that's done on a drop of blood, and it essentially measures the integration in cells versus plasma, and it's a 1-to-1 ratio, which is how it's confirmed as chromosomally integrated. Next slide, please. Okay, so this is a patient, a 25-year-old fellow with AML in second remission, referred from a rural hospital where he received his initial treatment. He's preparing to undergo an allogeneic transplant from an HLA-identical sibling donor. He is CMV seronegative, and his brother was CMV seropositive. Immediately prior to beginning conditioning with high-dose cyclophosphamide and total body irradiation, a PCR for CMV in the patient is reported at 1200. The patient is asymptomatic, and his chest CT shows no infiltrates. So at this time, you would probably do what? Okay, great. Well, the answer is, the preferred answer is A, temporarily abort the transplant. And it's a little tricky because, you know, the patient did relapse and you're worried about relapse and you want to move on with the transplant, but it looks like this patient has been in remission and you may have a short period of time to actually treat a primary CMV infection. So he has an unusual situation where his CMV turned positive just as he was ready to begin transplant or begin conditioning. And if possible, then the transplant should be postponed and the patient can be treated with ganciclovir. GCSF is, with regard to the other choices, is used with ganciclovir if the patient's neutrophil count begins to drop below 500. But again, one wouldn't proceed with transplant with that in mind. The mortality rate would be too high, even with this treatment. There's no role for immunoglobulin as a sole treatment for CMV PCR positivity, and immunoglobulins used with ganciclovir for CMV pneumonia is sometimes done, but this fellow doesn't have pneumonia. And ganciclovir is usually used alone for CMV enteritis if we're talking about how is immunoglobulin therapy used or not used. Next slide. So there's no established role for a hyperimmune globulin product for CMV. And again, continuing the transplant is not recommended due to early mortality related to CMV. And it emphasizes the importance of routine screening of patients for CMV PCR positivity to avoid just exactly this kind of event. So I think before I left Seattle a year ago, we were doing this pretty routinely. It was a standard part of our pre-transplant workup, and clearly would put the transplant on hold in almost all cases. Next slide, please. A 62-year-old transfusion-dependent female with MDS undergoes non-myeloablative transplants from an HLA-matched sibling donor. Treated with fludarabine and total body radiation. She receives standard CMV prophylaxis. With MMF and cyclosporin, she has an uneventful recovery, but develops grade 3 graft-versus-host disease. Is treated with 1 milligram of methylprednisolone, which is tapered slowly after an initial response. Other medications, as you can see there. On day 46, she develops confusion, disorientation, a lumbar puncture is negative, and an MRI shows the following changes. Next slide. So you can see some changes here in the posterior area, which are considered white matter changes on the MRI. Next slide. So the most likely diagnosis is okay. Well, good. So the answer is C, cyclosporin toxicity. Next slide. So this patient has CNS changes that are likely related to cyclosporin producing what we talked about previously, that is the PRESS syndrome, posterior reversible encephalopathy syndrome. These changes are usually reversible by stopping or changing immunosuppressive medication. White matter changes in the temporal areas are characteristic. And the incidence of this is usually about less than 10%. It often can happen actually in older patients. Usually occurs in the first 30 days, but not necessarily. And the rate of this being associated with tacrolimus or cyclosporin increases with the presence of GVH or intense conditioning and perhaps the degree of graft mismatch. Next slide, please. So the other things in the differential would be leukoencephalopathy. Steroids can sometimes produce CNS symptoms, particularly in elderly patients. However, we would not expect white matter changes as we saw in this MRI. Less likely, but possible, is our friend HHV6, which can produce CNS changes, including memory loss and disordered thinking. In this patient, we didn't comment on the HHV6 level, but the CSF analysis was quote unquote normal in this patient. Graft versus host disease of the brain is very, very rare, and I don't believe I've ever seen a case. Next slide.
Dr. Stewart, may I ask you a question?
Sure.
Do you change cyclosporine to another immunosuppressive agent in this situation, or after temporary discontinuation of cyclosporine, you restart it at a lower dose?
Well, you know, if you look at the literature, it's possible that sometimes if you go from tacrolimus to cyclosporin or vice versa, that patients will get better. My experience hasn't been too successful in that regard. Can you go to other medication like sirolimus? That probably would be an alternative. Other modalities for controlling GVH are possible. I think the first line might be to switch your calcineurin inhibitor and give it a try. It depends upon how effective you know, your treatment has been for graft versus host disease. So if your graft versus host disease is under control, switching to a lower dose of a different calcineurin inhibitor might be an approach. Switching immunosuppressive drugs in general might be an approach. I think you almost have to try it and see how it works, but certainly holding it for a little bit, if you can, to see if the symptoms clear, is a good thing, assuming your graft versus host disease will stay under control. Sometimes that requires bumping back up. If you taper the steroids, bumping the steroids back up to some extent to cover for that change in cyclosporin. So it's kind of an artistic balance, if you will, based on the state of the patient.
Thank you.
Okay, 55-year-old CMV seronegative female with myelofibrosis and massive splenomegaly, severe anemia, and thrombocytopenia, undergoes transplant with high-dose Cytoxan, busulfan, followed by peripheral blood stem cell transplant from a CMV seropositive matched unrelated donor. She received cyclosporin and methotrexate for graft versus host disease prophylaxis plus ursodiol. After one dose of methotrexate, her creatinine increases and she switched to MMF. She has a dramatic decrease in the size of her spleen, probably based on the conditioning regimen. And at day 8, she develops weight gain, a direct bilirubin of 6.9. Ultrasound confirms hepatomegaly. She develops fever on day 9 and is treated with broad spectrum antibiotics. On day 36, her bilirubin increases further and she develops profuse bloody diarrhea with abdominal cramping. Endoscopy shows erosive changes in the colon. Biopsy is inadequate for tissue diagnosis and infectious evaluation, just to complicate the case. Cultures are negative for viral cultures and Clostridium difficile, and she started on 2 milligrams per kilogram daily with minimal change. So which of the following best describes her condition? Oops, did we lose the slides? So I think you got the right answer. This is sinusoidal obstruction syndrome, answer B, followed by grade 4 graft versus host disease. Patient has a very, very poor prognosis. So it's worth backing up to look at myelofibrosis and extramedullary hematopoiesis. It's been said that those patients that are at slightly higher risk of developing sinusoidal obstruction syndrome. So this is a term that replaced, at least in Seattle, veno-occlusive disease, VOD. And it probably speaks more to the mechanism for how this syndrome develops, which I'll show you in a moment. Some centers reverse the order of busulfan and cyclophosphamide for a variety of reasons, including the hope that you're not depleting protective enzymes that might detoxify drugs like cyclophosphamide. And cholestasis lenta is an entity that we see sometimes an isolated increase in the bilirubin in the presence of fever or sepsis or even total parenteral nutrition or even cyclosporin. And it usually, the bilirubin usually returns to normal once those factors are under control. So steroid refractory gut graft-versus-host disease, as we know, has a very poor prognosis. I think ATG is used as second-line therapy, but of course, Jakafi would be probably the treatment of choice. And MMF, as I mentioned before, can sometimes cause GI symptoms, but usually not as severe as you would see here. This patient was on MMF. Good to think about it, but I think the severity here is a big factor. My FORTIC is the preparation of MMF that minimizes GI toxicity if you think that that's playing a role. An alternative approach might have been to use a reduced intensity conditioning regimen, such as fludarabine, melphalan. Next slide, please. So I think this slide indicates, or this case kind of indicates the timing sequence for when complications develop. And you can see that SOS, mucositis, cytopenias, bacterial infections occur fairly early in the course. Now you remember this patient had symptoms of fluid retention, hepatomegaly, rising bilirubin within almost the first week following transplant. And that's pretty characteristic of sinusoidal obstruction syndrome. There are late cases that are described, but a lot of the cases occur sometimes in that first week or 10 days. Unlike necessarily graft-versus-host disease, which may occur sometimes early, but often later after engraftment has been achieved. So the timing there, our friend in Seattle, George McDonald, often indicates is a good way to begin to direct your suspicions for what's actually causing the problems. Could we hit the arrow again for a second? There's another part of the animation here. So this then shows, again, on the timing, shows the timing of when some of these complications develop, and you're all familiar with those. But suffice it to say that GVH would likely follow sinusoidal obstruction disease or syndrome as it did in this case. Next slide. So, you know, this patient had hepatomegaly. There are a lot of different causes of hepatomegaly in a transplant patient. One is right-sided heart failure. Another is clotting of hepatic veins leading from the liver to the inferior vena cava with hepatic vein thrombosis. And then the third one is veno-occlusive disease or sinusoidal obstruction syndrome, where the central vein basically is obstructed. Next slide. Now, the way this works is as follows. The top diagram here shows the anatomy of kind of an hepatic venule or hepatic cellular lobule, so to speak. And you have on the left incoming flow from the portal vein, the bile duct, and the hepatic artery. And that blood percolates through these sinusoids in the liver to exit in the terminal hepatic vein. And you saw a diagram of the hepatic veins exiting the liver and going into the inferior vena cava. Now there are tiny cells that line this sinusoid called sinusoidal endothelial cells. And they have these little fenestrations. You can see them there. They're very flat on the internal lining. And they're probably susceptible, more susceptible to chemotherapy and radiation, as an example. So that when those cells die, the fenestrations loosen, they break apart, and it's kind of like having a plastic liner in a metal tube. If there are tears in that plastic lining and you have high pressure liquid flow through that tube, the plastic may collapse downstream and block the tube. I think the same phenomenon can be envisioned here, where those sinusoidal cells basically come apart and the blood flow is slowed, stopped. It may sludge and clot and put pressure back, reverse, into the portal vein, which of course leads to hepatomegaly. It leads to ascites, and of course the pressure on the bile duct leads to an elevation of the bilirubin. So this is why George McDonald at Seattle renamed VOD sinusoidal obstruction syndrome. So it's worth kind of going through that mechanism. Next slide. Any questions about that, by the way? Okay, case 10. We're on a roll. A 45-year-old male undergoes high-dose cyclophosphamide, etoposide, total body irradiation, followed by autologous stem cell transplant for relapsed large cell lymphoma in near second complete remission. He received Bactrim. He's CMV positive, HSV seropositive, has a history of hepatic candidiasis in remission. His pre-transplant DLCO was about 62%. He had a slightly elevated indirect bilirubin, and he developed severe mucositis after his conditioning. And then on day 12, he experienced a sudden onset of shortness of breath, oxygen desaturation, and fever. His chest CT, you'll see in a moment. His bronchoalveolar lavage reveals a bloody transudate. Infectious disease studies are pending. But from what you know now, the most appropriate treatment would include, and let's look at the CT first before you make your judgment. So there is the CT scan. So you can see diffuse infiltrates there. Somewhat of a little bit of a paving pattern. Next slide. Next slide. So here are the choices. Palifermin. You guys are quick. Okay, well, you got it right. Most of you got it right. The answer is high-dose steroids, platelet transfusion to keep the platelets greater than 100,000. And so this patient has diffuse alveolar hemorrhage. Next slide. So the CT scan findings and the blood noted in the bronchoalveolar lavage certainly makes one think of diffuse alveolar hemorrhage, even before you have the infectious disease markers back with that pattern. One would want to try to institute steroids and platelet transfusions. So with regard to the infectious workup in someone who has an auto transplant, CMV would be less likely We don't usually see CMV much in auto transplant, although it can occur. If a BAL is negative, then that usually would, of course, exclude CMV pneumonia. Gang cycle bearer, therefore, it wouldn't be indicated. Pneumocystis would be unlikely since he's on prophylactic Bactrim. Palifermin would have been a reasonable choice up front for this patient to reduce the severity of the mucositis with this particular regimen, which was a very toxic regimen, total body radiation, Cytoxan, and BP16. We typically use palifermin in that regimen, but it wouldn't have done anything to prevent the lung complications that you see in this patient. So next slide. So these are some findings of diffuse alveolar hemorrhage. You can see on chest CT, you can see the blood here in the bronchioles. Next slide. And one of the things that is a characteristic, and it's not absolutely characteristic to the exclusion of all other diagnoses, but one of the characteristics is this, what's called crazy paving, where you see this paving and it's kind of in different patterns. And you can see it there on the left, perhaps with your imagination. You can see how that might be a sign that a radiologist might use that would lean in favor of diffuse alveolar hemorrhage. Next slide. So the other finding in diffuse alveolar hemorrhage is as you do your lavage, instead of clearing blood from the lavage, the bleeding actually gets worse. So if you look sequentially here from left to right, the concentration of blood in that lavage actually is getting worse. Another sign that you're dealing with diffuse alveolar hemorrhage. Not too unexpected to get maybe a little bit of blood that would clear on other BALs, but this is much more suggestive of diffuse alveolar hemorrhage. Prognosis, of course, is very guarded. And even though patients may respond initially, relapses are unfortunately common. Okay, 56-year-old male with a history of JAK2 negative myelofibrosis, underwent a matched allogeneic transplant, was treated with tacrolimus and methotrexate as prophylaxis for GVH. He engrafted day 23, but had mild cytopenias. He developed hypertension and hemolysis with increased transfusion requirements. His platelet count was 30,000, had an indirect bilirubin of 5.6, a high LDH, and an undetectable haptoglobin. There were moderate numbers of schistocytes found on his peripheral smear. Direct Coombs test was negative. Creatinine went up to 1.9. His condition did not improve with continued transfusions. He had biopsy-proven moderate graft versus host disease, also abdominal pain, and guaiac-positive stools, but no frank bleeding. Next slide. So, which would not be the correct answer here? Okay, well, so this is a kind of a difficult one because there are elements of truth in many of these answers. First of all, you would want to discontinue or replace or reduce the tacrolimus and control the hypertension. That would be something you would want to do. You might want to order an Adams 13 and serum complement levels as part of a diagnostic workup. it's likely that the patient has microangiopathic hemolytic anemia that we sometimes see post-transplant, and eculizumab would be a drug of choice to try to control that. You would also want to try to control the graft versus host disease. Endoscopy with biopsy would be things that you could do as part of the initial workup. Moving to plasma exchange followed by splenectomy, if no response, would probably be the outlier here. I can't remember any splenectomy that we've done with this disorder. Plasma exchange has been tried, but is usually not very effective. And so this basically is kind of summarizes the first four answers, kind of summarize the approach that you might take with this patient. So in a way, the worst answer would be the last answer of the choices. And this pretty much says what I just said. It's the Adams 13 is appropriate to rule out the rare possibility of TTP. It's unlikely to be positive in the transplant-associated microangiopathic hemolytic anemia, but would be a reasonable test to look at. Serum complement levels can sometimes guide the administration of eculizumab, which may improve in 50% of patients treated who have transplant-associated microangiopathic hemolytic anemia. And then finally, endoscopy with biopsy showing GVH, but also showing TMA. You can actually see the microangiopathic clotting or changes in the biopsies, and that portends a worse prognosis as well. So that lowers your response rate. Next slide. And of course, eculizumab is a good drug. Plasma exchange is unlikely to be effective, as I mentioned, unless it's TTP. Sometimes splenectomy is used to improve transfusion requirements, but would not be here an initial consideration. Next slide.
May I ask a question?
Sure.
You know, the eculizumab is not readily available in Iran. So what's your recommendation and alternative choice? We know that evidence for rituximab is in transplant-associated microangiopathic anemia is limited. Do you have any experience about the rituximab or some agent like defibrotide for this problem?
Yeah, no experience with defibrotide. I know rituximab has been tried, but not terribly effective. It's a really tough situation. I think, one of the things that you can try to do initially is the first answer, and that is to try to get the patient off the cyclosporin, but sometimes that doesn't work either. It's difficult, and even eculizumab has its failures. There are some new drugs coming down the pike for this disorder, which may be even more effective than eculizumab, but the choices are tough. I would say, moderating the drug therapy, trying to control graft versus host disease without using cyclosporin would be the choices. You could try Rituxan, but again, I think the reports are pretty sparse that it works. It may anecdotally work, but not a strong indication. Okay, other questions? This just shows the mechanism of action of eculizumab. It interferes with the complement pathway at C5, preventing the membrane attack, which pokes holes in red cells and causes schistocytes to occur. And of course, that's slowed down. Again, there are patients who are resistant, become resistant to eculizumab, or who have difficulty tapering off eculizumab. It's, as you pointed out, sir, an expensive drug, no question. Next slide. So I'm seeing where, let's see, it's now available. So that's good. Okay, this is our last case. Are we over time, Marjan?
We start late,
Yes.
so we have some times. Yes.
We have some time, yeah. A few minutes we have time after the last
Okay.
case. And the people can ask their question if they like.
All right, so this is a 54-year-old male in good clinical condition, scheduled for an allogeneic transplant to treat high-risk AML in first complete remission. So the key is high risk. Since he lacked a suitable HLA-matched sibling, an unrelated donor search was initiated, and he was typed at those loci that you see. And he then had the immunogenicity T-cell epitope determinations and the expression genes that I talked about before. A is low expressor, G high expressor. You'll see this in a moment. And understanding that HLA-DPB1 is often mismatched in donor searches that otherwise show identity, given the patient's clinical condition with high risk for relapse, which donor would you select? So let's go to the table and take your time. I don't want to move to the answers yet. So let's hold this next slide and go through it. So you see here, the patient is at the top, and then you see the different HLA A, B, C, DR, beta 1. Those are to the left of the red line. Those are the most important HLA antigens to match. To the right of the red line are the DQ, DP, and so forth. This is where the patient is, or where the donors are potentially mismatched. And then you see the T-cell epitope determination, which is permissive or non-permissive, if you remember my slide. And then you see the SNP proxy for the expressor gene, either A or G. And then you have a summary in the last column of the HLA allele matching. And so you see the total number of allele matches. So donor number 1 is a complete 12 out of 12 match. Donor 2 is 11 out of 12. Donor 3, 10 out of 12. Donor 4, 9 out of 12. So looking at that, well, well, go ahead, keep going. All right. Okay. Are we done? All right, let's go to the chart here and walk through this. Does anyone want to volunteer to walk through this? Or do you want me to walk through it? Okay, I will walk through it, but you guys got the right answer. The majority got the right answer, so kudos. So the first one is tempting because it's a 12 out of 12 match, right? And you see all of this, the epitope is permissive, it's a low expressor, so low graft versus host disease. So not a bad choice, right? Might classically think that would be the answer. The one you could probably exclude right away is donor number 4, where you have a major mismatch, right? So that kind of kicks that donor out. Much worse than the other donors here in terms of a major mismatch. So you're left then with donor number 2 and number 3 and number 1. And what do you think the difference is? What is striking about these 3 donors. Anybody want to volunteer? I don't know if you can turn your speaker on, but maybe not. Well, the striking difference is this donor is much older, right? And remember I said that it's about 3% mortality per decade difference. And so using this donor would confer a significantly higher mortality rate as a factor. And then you're left with 2 younger donors, which that's appealing. But if you go over here and you look and you see that really there are 2 mismatches here, and the epitope type is non-permissive, which means it's associated with more reactivity. It also has a G expressor, which is going to increase your graft versus host disease rate as well. So this one is probably not appropriate. However, this one I think would be the choice. And this was actually presented in the 2 years ago in one of the ASH educational sessions, and I changed this case around a little bit to make some educational points. But this case, the donor number 2 is the optimum donor because there's a little bit of a mismatch here, which will help with an anti-leukemia effect because it's shown that in this DP beta 1, if there is a mismatch there, that confers a greater anti-leukemia effect. But it's not going to create such a graft versus host disease effect that this donor would, that it might affect mortality in an adverse way. So a gambler would basically select donor number 2, understanding that there probably is no perfect answer here, but that would be how the ASH presentation of a couple of years ago would select a donor out of this choice. So I thought this was a really good exercise to go through. And if you get a copy of the slides, I've gone into more detail on this particular case. It's not an easy one, but you all did quite well. So why don't we stop there? Marjan, any questions? So the answer is B, of course.
Thank you, Mark. If the audience have any question, they can ask. We have 5 minutes time.
And I want to thank Dr. Shadman for joining me. That's a treat. And the other thing I might say is you all did very well. So, you know, I think the Iranian physicians are winning over the United States physicians, but don't tell anybody I said that. Not surprising since Dr. Shadman, now, of course, I know how brilliant he is, and I understand he came from a great country with excellent education. So you should be proud, Najar.
So if I may say a few words, I didn't get a chance to say hi, Dr. Stewart. I just wanted to say we really miss you here in Seattle, and thank you very much for this great presentation and talk, and I hope this is a beginning for more collaboration between our colleagues in Iran and City of Hope, and thank you for that.
Yeah, absolutely. Any questions? Did I put anybody to sleep? I saw most people responded, so that was a good sign.
Thank you.
That
was great. And I think it was very helpful, comprehensive, and excellent. I hope to see you in next virtual meeting very soon.
Great. Well, thank you guys for having me. It's been a pleasure.
Thank you, Professor Stewart. We don't have any questions, so we should finish the session. Thank you very much.
Thank you.
Excuse me, Mark. Dr. Musavi, director of our institute, would like to say thank you. If I don't know if Dr. Musavi is online, but we gave him the microphone. Dr. Musavi, are you online and can you hear me?
Thank you, Dr. Yakmai. I'm Dr. Musavi, Head of a Research Institute for Oncology, Hematology, and Cell Therapy, affiliated to Tehran University of Medical Science. I'm glad about your nice presentation and very good discussion of question. Thank you very much, Professor Swart. Thank you, my colleague, Dr. Shadman, for collaboration, and thank you, my colleagues, Dr. Yagmai and Dr. Rad and Dr. Rostami. Thank you very much. Bye.
Thank you very much. I really appreciate that.
Thank you, Mark, for your excellent presentation. Hope to see you very soon.
All righty. Take care. Bye-bye.
Okay. Bye. Have a nice day. Bye.